Thank you very much. The first thing I wanted to do is to thank you guys for coming and showing up today. This community track is new to Black Hat. It is something that has been talked about for a long time, and we're very excited to have these kind of talks here for the very first year. But the first thing that I want to do is give a little bit of a disclaimer. While we're going to talk a lot about medical issues and mental health issues, I want you to know that I am not a doctor. And even though that this guy is a doctor, he is not your doctor. So we want to tell you that if you see things in this presentation that vibe with you and you're like, that sounds a lot like me, that you might want to consider seeing your physician and seeking out treatment for yourself. We're not going to be giving very specific treatments to you, just general advice and kind of anecdotal stories, personal stories from both of us about how mental health has affected us, but we don't want you to take that as direct treatment information.
And then just make sure you also, when you're asking questions or later on in the Q&A, people are very passionate about their history and what's going on with them currently. We want to make sure that you don't share any of your protected health information, any of the stuff that makes you identifiable or what's going on with you, with everyone else. And then lastly, it's just really, really important and really in theme with the community track this year that we are all a family, hackers, InfoSec, all of us together. So you really need to treat others with dignity and respect.
Yeah, and especially the thing with talking about very personal things, like I don't want people to come up to the microphone and be like, well, I am this, this, and this, and I take these medications. We can talk about some of that stuff, but we'd like to prefer, there's going to be some more time and availability tomorrow to talk about that in a more personalized setting.
So my name is Christian Dameff. I'm an emergency physician. I'm also a clinical informatics fellow at the University of California, San Diego. Interestingly enough as well, I also do security research. So along with Jay, I research medical devices, critical medical infrastructure, and I'm curious and concerned about how this technological infrastructure are going to harm my patients. But more important than that, I treat emergent medical illnesses, mental illness in the emergency department. I'm not a psychiatrist. I don't handle long-term depression, these types of things, but I handle the emergent issues around mostly suicide. And then in theme for today, I'm often a burned out person. I'm sure you in the audience are also, because it's just so prevalent in what we do. And I often suffer from imposter syndrome. Here, speaking in front of you here at Black Hat is a true honor and something I never thought I would do. So when I come here and speak and be on stage with such greats like Jay, it really puts my imposter syndrome at over 9,000. So with that being said, I also have some baggage. Follow me on Twitter.
I'm Jay Radcliffe. I am a cybersecurity researcher for Boston Scientific. They make medical devices. This is probably my 6th time speaking at Black Hat. I do a lot of work in breaking into medical devices, hacking into things, and kind of speaking on the topic. I've also spoke many times at B-Sides and DEF CON on different topics related to the scientific method and mental health in general. It's kind of important to know that I'm a type 1 diabetic. I was diagnosed on my 22nd birthday, and it really makes up a big component of what I am and who I am. It's the reason I'm on this stage today. 7 years ago, I presented some research that I did here at Black Hat, which was one of the first times a medical device, an insulin pump, was hacked, and presented that and did a demonstration of it live on stage. So, I mean, without my being a diabetic, I wouldn't have access to those types of devices and access to do that type of work. So it's kind of a dual-edged sword. I'm excited that I'm a diabetic, but it also kind of sucks being a diabetic at the same time. Other things you need to know about me is that, let's say I'll use the term flawed. I have some issues, right? I am divorced. I have a lot of anxiety. I am depressed. I have ADHD, I have thyroid issues, and in combination with a bunch of other medical things, which we'll talk about later, which kind of impact my mental health and impact how I operate from a day-to-day basis. But one of the things that's important to know throughout this entire talk that we give is that even though I am all of those things, I am still successful and productive and functional. And people that have mental illnesses and have mental health issues can also be very productive and very happy if they use the resources that are around them. And that's a big reason that we're giving this talk today, is we want to give you a glimpse of some of those resources and some of the things that you can do if some of these symptoms speak to you and you identify with some of them.
So we're going to start our discussion today with a patient's story. I've removed any identifying information, but this is actually a real patient of mine. We're going to call her Jane. Jane's going to visit us a few times during this presentation, and this is her first visit. Jane is in early 20s. She's had a rough life. She comes into my emergency department, and she tells me that she wants to hurt herself. Who is this person that's listening to her? Well, it's this happy young doctor within 2 weeks of starting his residency. So you go to medical school, you get your degree, then you go to residency, and anywhere from 3 to 7 years, you learn what it's like to really be a doctor. You learn how to take care of patients. So 2 weeks on the job, 2 weeks being a real doctor, brand new, fresh, bright-eyed, bushy-tailed, can cure any disease, diagnose anything. Jane comes to me. She tells me she wants to hurt herself. She tells me about her PTSD. She tells me a lot about her prior sexual trauma. She's never tried to harm herself before, and she said, I had these thoughts of hurting myself. I came to the emergency department. I didn't know where else to go. So quickly, I go to her bedside. I sit down. I talk with her. I'm there for half an hour listening to all of this, listening to her, recording what she's saying, being there for her as that role of that ideal physician. I call the social worker. I order all the tests I'm supposed to do. I check on her frequently. Many people come and evaluate her during the hours and hours and hours that she's in the emergency department. And they all kind of get together and they agree. Jane's probably safe to go home if she does a safety contract and she goes home with family that'll watch her, and she follows up with mental health professionals shortly afterwards. Everyone agrees. She agrees. She goes home. This young, happy doctor goes back to learning what it's like to take care of gunshot wounds, trauma, severe infections, and sepsis. I don't know if she was the first patient I told this to, but I think she's the first patient I remember telling this to. And I say this to all my patients that come to the emergency department, that come in there with suicidality. I tell them the following kind of words, these sentences. If you ever find yourself without hope or help, or you feel like you might hurt yourself, you feel like you might make a decision you're going to regret, find the closest emergency department. We're not going to be able to fix your issue. We're not going to be able to cure you, but at least we're going to be able to help you. We are open 365 days of the year, 24/7. All right? We'll be there. We'll help you. And she left. So let's fast forward a year later. I'm burned out. I've been working 80 hours in residency. I just finished 4 weeks in the burn ICU, where I saw some of the most sickest patients with tubes coming out of every part of their body, and then having every type of infection you can imagine, seeing the anguish of family, etc. And I was burned out. I was cynical. I had no satisfaction from the accomplishments that I had done in my life up until then, or I was doing on a pretty regular interval. I never took a chance to celebrate any of that with my family. I dreaded going to work. I felt powerless. I felt like the system was broken and the patients I was trying to help couldn't get the help that they needed. And I felt like the insurance companies and the drug companies and everyone was mounting up against my patients. And I was really, really frustrated. I had a clear work-life imbalance. I was at work at 4 a.m. I was there until 8 at night, and I would repeat. And then all that stuff you see, all the drama in the emergency department, the sick kids, sick grandmas, sick moms, car accidents, it kind of weighs on you. So I was burned out after a year.
You know, and I think that resonated with me too when we talked about this. And it might resonate with some of you. All of those symptoms of burnout that he just described are things that are very prevalent in the information security community. I know that when I look at my friends and their job history, that quite often They leave and find new jobs after a year and a half, maybe even less. Why? Because they're burned out. They get tired of the rigmarole of feeling like they're just bashing their heads up against the wall. They get tired of the work-life balance being out of whack and all you do is work and travel. Personally, I have gone through this. And what I find my symptoms to be is that tasks take a lot longer. A report that might take me a week to write now takes 3 weeks to write because I just don't wanna. I don't wanna do it. I can't find the energy. I don't have any joy in my work. I mean, hacking into things is really fun. But when you're depressed and you're burned out, it's not. Things that you found joy in before, even little things, going to the movie, having a nice cocktail or a meal, when those become joyless and fun, no fun, that's probably a problem. I always find that sleep is a big symptom for me. I want to go to bed right away. I want to stay in bed and sleep until I can't anymore. Those are big symptoms of depression and burnout. The desire to leave your job and to find a new one. Oh, if I just left this job and found someplace better, it would be, but I would be happy. I see people in information security doing this all the time. People job hop for a reason. And then sometimes it leads to destructive behaviors. When you're depressed, sleep deprived, unhappy, you make bad decisions. You might call out your boss. You might do work that's subpar. You might do things that are destructive to your career or to your personal life. And those are big problems and big symptoms in burnout and in depression. When I look at information security job stress, there are some big factors. One of the reasons that we have this community event and things like B-Sides as well is this is a major problem, and we know it's a major problem. When we look at the ISSA study done this year, 68% say that it impacts work-life balance. That's huge. That's the majority of people find that there's a work-life balance problem in their jobs. There's also a lack of training. They're doing so much work that they don't have time to train. Lack of staffing. I don't need to repeat that there's a shortage of cybersecurity talent. So what do? Well, we work the staff that we have extra hard to get that work done. And there's increasing of demands. Everything is being digitized. Everything is needing our security help. So we have to be the heroes. We have to be the ones to shoulder that entire responsibility. There's also, going back to 2010, the study that Jack Daniel did at RSA and B-Sides Las Vegas, with the symptoms of burnout and how prevalent they are in our community. I think on top of this, there's this additional pressure. There's this additional kind of depressive theme, and that is social media. No matter what side you're on, it is corrosive, and it is troublesome, and it is problematic. The amount of rhetoric that's going on in social media, in our own community even, it's becoming a big problem. We just have to look maybe back to Hope last month and the problems that they had there to see that this is a problem that's springing up everywhere. When I saw and did some work, I also saw that there's a study that showed people who were active on social media are 3 times as more likely to be depressed or anxious. That's huge. There's a reason that people drop out of social media. It's because it's depressing. I mean, when I read my Twitter stream, sometimes I'm like, nope, I can't do it. I can't deal with that today. It is too much. It is too negative. It is too toxic of a place for me.
All right, so we're going to go to Jane's second visit. It's a year later. We got a crusty, burnt-out doc. I go to her bedside. I don't remember the encounter very well. Probably for a variety of reasons. I'm seeing dozens of patients a day. And I go to this patient who's on the board, a big track board, and it has a room number and a column that says suicidal. I assign myself to the patient. I walk into the room, and my resilience, my reserve, my compassion is gone. And I know that now I'm going to have this interaction with a patient who's a number, and just I know is suicidal, and I have to check off these boxes. Check them for overdose, do these blood tests, make sure I ask these specific questions, put it all in a note, call the right people, and repeat. So I do that. I don't remember the encounter very well. And I get up to go, and she says this to me. She says, "You were very different the last time you treated me. Where did your kindness go?" And at that moment, I didn't even remember that I had taken care of her a year previously for the exact same issue. This struck me like lightning. I sat down, and I did what I should have done to start. I did what I did a year ago, and I listened to her. We talked. And it was good for both of us, because I recognized how much I had lost, how much I was burned out, and how much it actually impacted a person where it mattered the most. A patient at the end of a rope, a patient who's had a horrible history, who needs help. Because the thing she said afterwards was, "The only reason I'm here is because last time I saw you, you told me if I had nowhere to go, no hope, and no help, to find you." So I committed after that day to listen to all the wise doctors around me and start doing a burnout inventory. There's a bunch of tools you can use. Some of them require, like, you have to pay for them, etc. You can find these things. But there are tools where you can measure how burnt out you are. Okay? And every 6 months, I went in to see my boss, and we sat down together, and I love my boss. I had a great relationship with him. We did a burnout inventory together. And he pulled the one out from 6 months ago, and he compared it. And he said, "You're up 3 points. What's going on?" And we talk about it. I had a pulse and a gauge on my own level of burnout. I saw trends. I recognized where I needed to improve myself. And I kept the patient as the most important gauge of that. If I saw my patients being frustrated, if I saw myself spending too little time with them, if I saw that I wasn't treating them like human beings, I recognized it was a failing of my own burnout. Back to the patient. I also committed at that point to not treat her like a number and the complaint of suicidal, and instead learn a little bit more about this complex thing, the brain, mental health, and how we treat. I put up the DSM-5 not because to cause a kerfuffle or to cause controversy, but just to show you that there was a real problem back in the early days of psychiatry about what's the language we use to talk about different mental illnesses. Dr. A called schizophrenia this and said you had to have these elements to get it, and Dr. B had a completely different name for it and completely different diagnostic criteria. So when people would go to get treated, they'd say, "I have this and this and this," and the doctor would say, "Well, I don't think you have this diagnosis." There was just no common language. The syntax wasn't shared. So they came together and they wanted to write down, these are the diagnoses that we know about, and here's the criteria that if a patient has these things, they may have this mental illness. The DSM-5s often considered the most authoritative texts on what those definitions are, and is generally considered to be pretty comprehensive. It is sometimes controversial, and that's probably saying it lightly. As versions change, this is version 5, as versions change, different diagnoses are added. So people who wouldn't qualify for mental health 12 years ago with the DSM-4, all of a sudden now they have a mental illness because a new one's put in a book. Perhaps we made the bar to diagnose a mental illness lower. We said, instead of having 4 out of the 5 of these symptoms, you only have to have 2 out of 5. So then a lot more people all of a sudden have this mental illness. And the only thing that changed was the definition. And there was also controversy around autism and diagnosing children with autism with the change. It made it harder to diagnose children with autism. And some families found it really hard to get benefits and extra help with things like educational resources because their kids suddenly weren't diagnosed with autism anymore because the definition changed. With that being said, I think there's still some utility in talking about it, and briefly we're going to go through some different categories of mental illness just to show you more than anything else, don't take notes, there's a lot of stuff going on. And we think about this stuff as doctors. Depressive disorders, major depressive disorder, persistent depressive disorder. These are the symptoms of sadness and hopelessness. These are people who have a lot of the symptoms that we just talked about when it comes to burnout, when it comes to wanting to sleep, withdrawal, isolation. The other thing I want to bring up here, and Jay's is going to also chime in on this. Look at the second from the bottom. Depressive disorder due to medical condition. The human brain is so complex. And while doctors sometimes think they know the answer, we are pretty clueless when it comes to how the brain works most of the time. We could diagnose someone with having depression because they have another medical illness, but it's complicated. It's not just maybe you have a medical problem and you have depression. If we solve your medical issue, your depression will go away. These things are multifactorial and complex.
To give you kind of an example of that, let's talk about somebody who has diabetes. Every time that they have to eat, it is a long, arduous process. They have to check their blood sugar. And then they have to figure out exactly how many carbohydrates they're going to eat in that meal. Then they have to do a complicated algorithm to figure out how much insulin that they need to correct their blood sugar, and then to get the amount of insulin they need for the food that they're eating. If they're wrong in any way or shape or form, their blood sugar will be too high or maybe even dangerously too low. And it's something that they have to do every single time they eat, 3 or 4 times a day, every day of the week, every week of the year. It will never end. There's no cure for diabetes. There's nothing coming that's going to fix that problem. And that is depressing. It is depressing to know I am sick, I am going to be sick for the rest of my life, and there is nothing I can do about it. And I have this very fragile condition where if I figure out that maybe this piece of pizza has 5 less carbs in it than I thought, then I might have to risk going into low blood sugar shock. Or maybe it's got 20 more carbohydrates than I thought, and then my sugar's going to be high, and I'm going to have a headache, and I'm going to be thirsty, and I'm going to be miserable. Those are the things that go on, and that can make you depressed. There are actually a lot of books and materials written about diabetic burnout, of I have been doing this for so long, oh my God, I can't do it anymore. And that feeds in exactly to what we're talking about with an illness leading to depression or an illness feeding into these depressive symptoms.
There are other mood disorders, bipolar, substance-induced. Really, the point of this slide is to show that it's not always that you're depressed. Maybe you're depressed most of the time. And maybe in between episodes of severe depression, you're really happy and we call that mania. These things are complex and they don't always fit a pattern. There are anxiety disorders. I'm not going to list them all off, but this is a increasingly diagnosed medical condition in America for a variety of reasons.
You know, we talked a lot about some of the symptoms of burnout, and they look a lot like the symptoms of depression. Are you generally sad? Do you find that there's just not a lot of joy? You don't get a lot of enjoyment out of doing things that most people find joy in? Do you feel hopeless? This is pretty easy, and it rings a bell in information security. Do you feel like, you know what? This problem is never going to go away. They're never going to do things to secure their data, no matter how many times I recommend them. No matter how many pen tests we buy that have the same results, this company is just not going to change. It is hopeless. Why am I even here? Fatigue. It goes back to that sleep issue. You know, are you tired all the time? Do you want to go to bed at 6 o'clock and sleep until noon the next day? That's a problem if you just find that you're tired. Changes in your sleep patterns or restless sleep. What if you sleep for 15 hours but you don't get any rest? You toss and turn, you're constantly awake, Your brain won't shut off. It's constantly thinking, what's the next project that I got to do? I'm behind on this report. What about the kids? What's going on with this relationship? Am I happy at work? Why am not I happy at work? Can I get a new job? What if they fire me? All of those things could be keeping you from sleeping. Changes in appetite is a big one. People just stop eating. I went through a major episode in my personal life where I lost about 30 pounds in a month and a half. I think that I lived on Diet Coke and peanut M&Ms, but I didn't want to eat. No desire to eat whatsoever. Lunch, dinner, breakfast, didn't care. Like it didn't, and as a diabetic, that's very dangerous. But the urge, that sadness, that hopelessness is so overpowering that it can overcome basic needs like the need to eat, the need to shower, the need to take care of yourself. And that is where we get into some dangerous territory, when depression really leads to some bad things. One of the things that you can do if you find that you have some of these symptoms, or some of these symptoms ring a bell, is you can take a self-test and kind of see where you are maybe on this scale. It's a quick 9 questions, and it screens for depression. And when you have a test like this, and you can say, well, I don't know if I'm depressed, but let me check. Before you go to a doctor, you can do this. And then you can go to them and say, look, I'm having some of these symptoms. I took this test, and I scored this way. And that's why I'm here today, and I would like some help. I would like to get some resources to do this.
So we're not going to push medicines. I know I'm a doctor. I don't get my check from Big Pharma until tomorrow, so I'm not going to speak too highly of them until tomorrow. Just kidding. I don't get paid by Big Pharma at all. We're going to talk a lot about meds, not for the reasons that we're saying you need to absolutely go on meds, or meds are always the answer. Far from that. But they are often a part of treatment. So we wanted to put this in the middle before we talk about the rest of the stuff that's important, just to hopefully demystify it a little bit and to at least give you another take on this. But how do these meds work? We're about to talk about classes of medications. If I had a giant whiteboard behind me, you would see all these complicated biochemical pathways, arrows going from weird protein to weird protein and these weird chemical structures. To explain to you how these things would work, I'd go up to that whiteboard and I'd just do a bunch of hand waving. Because the answer is, we truly don't know how a lot of these medications work. We think we know, we think we have some hypotheses, but in actuality, we don't know how they fully work. We haven't explained it all out. But basically, we have these things called neurotransmitters in our brain. And they help control, or at least affect, mood. And when we give certain medications, they can modulate or control the amount or the efficacy of certain neurotransmitters. One of the things I want to talk about is something called a selective serotonin reuptake inhibitor. It's a very common class of medications, and it basically is going to increase the amount of serotonin in portions of your brain. Well, we know that this helps people. We give it to them and they feel better. They don't feel better immediately, but we measure the amount of serotonin immediately after we give them in the first few days, and it goes up. But they don't feel better for weeks. So we think the issue is serotonin. We can give you a drug that helps you with your serotonin. We can measure the serotonin and it goes up, but you don't feel better for weeks? That doesn't explain it. There's got to be something else going on. So I just wanted to bring this up to say there isn't going to be a clear answer. I don't think many people on this planet could convincingly explain to you how they work in their entirety. But what we do know is that they help a lot of people. I talked about SSRIs. These are going to be the most common class of drugs, and they deal with serotonin. There's SNRIs, which serotonin and another neurotransmitter, norepinephrine. There are some older classes of drugs, things like tricyclic antidepressants and MAOI inhibitors. Those are medicines that we don't typically use anymore because they had really nasty side effects. And the other thing I wanted to bring up, if you tried meds previously and they were of these older generations and you had lots of side effects, and you said, I'm never going to go on medication again, I'm never going to try it again, there's been a lot of stuff come out. There's a lot of new medicines that are out. I would offer you to at least think about revisiting them if that's something your physician recommends with you. There are mood stabilizers, the most common of which is lithium. These tend to treat these mood disorders we talked about, like bipolar disorder. But there are a whole other category of medications that may be used. This is a process. I wish we had a perfect medicine that had no side effects and worked the day you took it. I wish it was cheap and I could give it to people and it would fix their issue and this wasn't a problem. And we never had to talk about suicide. We never had to talk about depression because we had a great medicine that fixed it. The answer is we just don't. And to figure out if this medicine works for you, it's a process. It's not a one-time decision. Because of our DNA, it differs from person to person. The same drug may be metabolized much quicker in one person than the other. So they may need a higher dose. But the guidelines say to start at the same dose for both of these people. And we don't know if this person's going to metabolize it quicker and need a higher dose to start, or if this person's going to need a lower dose because their metabolism of the drug's really low. So we start this drug, and sometimes it can take 3-4 weeks before it even works. Maybe you wait 3-4 weeks and it doesn't work. Is it because you need a higher dose, or is it because the medicine's not going to work for you? That's why this is a process. And when you commit yourself to it, you got to work with your doctor and commit to figuring it out. And if it doesn't work for you after 7 days, it doesn't mean it's not going to work for you. You might need to continue down the road and try something else or another dose or maybe in combination with some other therapy.
All right. So it's my turn to be a little vulnerable. I'm going to tell you about what I take. And this is the way I look at it. I'm going to nerd out a little bit because I glazed over a little bit with the neuro uptake something or others. I look at these meds like I look at myself as a computer. These meds are like tuning kernel parameters. I came out of the box very inefficient. There's all these different parameters in my brain, from serotonin and the inhibitors and the uptake and all the chemistry that goes on. But thankfully, I have the ability to tweak those parameters. Now, anybody that's done any kernel tweaking at all knows that it can go good or it can go really bad. And you need to keep that in mind when you deal with these types of medications. So let's talk a little bit about what I take, okay? I take an antidepressant called Trintellix. Trintellix is one of the newest antidepressants on the market. It is the 5th antidepressant that I have been on in the search to get my perfect kernel parameter set for antidepressants. And it works pretty well. It generally keeps me in a better mood. It's easier for me to deal with my anxiety and my problems. Does this pill make me happy? No. Pills don't do that. They make it easier for you to be happy, but they don't make you happy. The second pill that I take is called Abilify. I have a Hulk tattoo, meditating, because I have some anger issues, and I have a very short temper. And Abilify helps with that ramp up of getting angry or losing my temper. And that works really well. I recently tried to wean myself off of it, and I discovered that that was probably a bad idea after the 3rd day, because I got angry pretty quick and my temper was pretty short, and that's how I knew it was still working. Strattera I take for my ADHD. It is a non-stimulant, and it really helps me with my general ADHD. When I don't take that medication, I forget to do little things. Like if I go get a glass of water, I'll open the cabinet door, get the glass, turn, and fill it up. But I won't close the cabinet door. Why? My brain is already off to the next task. The Strattera helps slow down that process for me, and it makes me more attentive to the things that I need to do to be functional. I also take another ADHD medication called Adderall, which is a stimulant. And the Adderall gives me focus. It gets rid of the distractions. If I sit down without Adderall at a computer, I will live in the Google, YouTube lands and watch videos and go from link to link to link to link. And I will not get my report writing done. But when the Adderall kicks in, it becomes a lot easier for me to write. It becomes a lot easier for me to focus. Again, Let's think about those kernel parameters. Let's think about tweaking the chemistry in your brain to work as efficiently as possible. I also take thyroid medication. Now, you probably know better than I do, when your thyroid levels are off, you can get a lot of the symptoms of depression. Low thyroid means you're really tired a lot, means you're really sleepy. Some people bruise very easily when they have low thyroid levels. So you have some of these symptoms that can impact your mental health and mental stability. I also take testosterone, which is horrible, right? It's this giant needle that I have to stab into my thigh once a week to give myself testosterone. But without it, my moods are all over the place. Like, I need the stability in my endocrine system for my mood, for my brain, and my emotions to be stable. That's just the medications I take for not my diabetes. Then there's all the ones I take for my diabetes. I take 2 different types of insulin, and I take a medicine called Farxiga for my insulin resistance. Now, let me tell you, every week when I have to fill my pill box for the week, it's depressing. I feel old, I feel broken, and it is depressing as hell. It's tough, and I have to do that every week from now until forever. And it's tough. And some of the ways that I've constructed that and changed that thought in my mind, I've done a couple different things. One is the kernel parameter tuning. The other one is I think of myself more like a really good European race car. You can't just put regular gas in a car like that. You have to put premium gas. You can't just put regular oil in that car. You need to put synthetic oil of a certain weight and a certain type. Everything in that car needs to be tweaked and tuned in order to get the best performance out of it. If you don't do that, you're going to have a horrible experience. So I like to look at myself not as broken and old, but more like a European sports car. I just need to be tuned and tweaked and fed the right things for me to be successful and for me to have a happy and fulfilling day-to-day life. Now, we'll give you one warning about some of these medications. You can't just stop taking them. This is extremely important. I did this once. I stopped taking my antidepressant Lexapro because I felt that I didn't need it. When you do that and you pull the rug out of the chemistry of your brain, it goes badly. I can understand people wanting to say, I don't need this anymore, but it's very important to work with your doctor on coming off of it the right way. You can come off of these medications, but you need to wean yourself off of them so your brain doesn't flip out. Because you can go into withdrawal symptoms and you can make your depression and all the other symptoms dramatically worse by just pulling the rug out and stop taking these medications altogether. So please be careful if you take these medications or in the future you take these medications, so you can keep that in mind. Now, there's lots of different mental health providers out there, and this can be very confusing, but they're all there to help you. There's counselors and clinicians and therapists, and they are generally great. They do a lot of talk therapy, and they can help you through a lot of these problems. There are psychologists with degrees and PhDs that can do more advanced things. EDMR is a very popular thing that psychologists do. There are social workers that do different things for different classes of people. Psychiatrists mostly specialize in medication. I see a psychologist and a psychiatrist because psychologists usually don't do medications. Nurse practitioners and family practice physicians also can dispense these types of medications under guidance and under different types of symptoms and different types of things.
And probably the most important out of this list, arguably, I would say, is not the doctor, although that's very, very important. And it's not that they're not doctors, just different doctors, the psychologists. Excuse me. They get a degree. They're trained in many different modalities and for many different health conditions, mental health conditions. And they're a good resource in almost every case. You've had a lot of experience with this, Jay.
Yeah. So I've been in cognitive behavioral therapy for well over 20 years now. It's something I do every week, and it's basically talk therapy where you figure out what your problems are and you talk about the solutions to it. I'll try and give a quick example here because we're pressed on time. I have horrible writing anxiety. I am constantly thinking that my writing is shit, it is horrible, and it makes me look like a worthless employee. And it freaks me out every time I write a report. And I have to deal with this anxiety. And I go and we do cognitive behavioral therapy, and my therapist says, "Has anybody ever told you your writing is horrible?" I say, "No." "And how many reports have you written?" "Probably hundreds." "Okay, so why do you think that your writing is horrible?" "I don't know. It doesn't make sense. It's just what I feel." So then we have to restructure that and how we deal with that and how we talk about that so that way my anxiety lessens. And by talking about it, even that process itself helps in that anxiety.
All without medication.
Now, this is one of my favorite slides. This is how I see my brain working. Remember, I think that I am a computer. This is my process table, right? And at the top of that process table might be depression, stress, report writing, my sick kid, social media, am I hungry? What's my financial state? What are my parents' state? These are all things going through my mind at a constant rate. How do I control this process table in my head? How do I re-nice these processes or reprioritize these processes? The thing that I have found to be most helpful is meditation. Now, meditation probably sounds like hocus pocus, but I've actually found it to be incredibly useful. In combination with my cognitive behavioral therapy, it helps me manage my process table. When I sit and I go through a 5-minute meditation or a 10-minute meditation, or sometimes even a 1-minute meditation, it helps reorganize that process table and reprioritize that process table to what my needs are, not to what my brain's needs are, right? So I don't worry as much about the anxiety of the report writing or what's happening at work. I can focus on the things that I need to focus on at that given time.
So we're going to go towards a little bit of depression into suicide. And this is obviously a sensitive topic. This slide is supposed to show you some warning signs that you should look out for in the people around you. We're a community, we're a family. These things don't always suggest suicide, but they're important things to keep on your radar. So if someone starts talking about harming themselves or starts talking more about suicide, perk up. If they talk about how much they're burdened or how hopeless things are, they're not going to be able to fix it and they are annoying all these people, that's something to perk up for. If you see their substance abuse getting worse, they're withdrawing, becoming isolated, if they start calling people and saying goodbye, or if they start giving their possessions away, those are things that you need to look at as red flags. And talk with that person and try to get them the help that they need. So there's a depression screening tool we talked about. Well, this is a suicide screening tool. You can find this one online. This Columbia Suicide Severity Rating Scale is quick. It's 6 questions, and it can get you a range about how suicidal this patient really is, or this person that you know is, your friend, your family. It's pretty sensitive, meaning that if you score a certain amount, the chance that this person's really suicidal and at that risk is pretty high. It's pretty reliable. So what do? These are 2 fantastic resources. Call, text. This goes many different states, all of them, so they'll be able to get you region-specific recommendations, guidelines, and help. This is where I'm going to be telling people to go. But of course, the emergency department is still always open. If you are without help, if you feel hopelessness, if you feel like you're going to hurt yourself, you got nowhere else to go, you come see me in the emergency department. It might not be fun. We always have horrible food, but we'll take care of you.
You know, one thing that I want to talk about on a positive note, is Project Semicolon. And, excuse me, I get a little choked up when I talk about this. Project Semicolon is a support group for people who have gone through suicide or have attempted suicide. And a semicolon is used when an author could have chosen to end a sentence but chose not to, right? And that is a very big metaphor for a lot of people who have attempted suicide. They chose to continue. They chose not to end their story. And I think that if you go to that resource and read what's there, it's very inspiring, and it's very fulfilling, and it's very helpful. So I recommend that you check that out.
So we're really short on time here. I'm going to talk to you about Jane's third visit. She came to me when I was a bright-eyed, bushy-tailed young doctor. She came back to me when I was burned out, and she helped me realize how burned out I was. I fixed it, and I helped other people, including her. Well, she came back to me a third time, but it wasn't because she was suicidal. She came back as a nursing student to my hospital while I was a resident and just said, "Hey, doc." I remembered her then, and I was inspired about her journey into healthcare so she could help other people, and she wanted to go and help people that were suicidal.
This is something that's super important this week. This week is huge in our community. People call it Hacker Summer Camp for a reason. You see friends here, you make new friends here. You reignite friendships that are old and new. These are the resources that everybody needs to survive in their day-to-day world. My friends are everything. I hang out with them, I talk with them on a daily basis. They are my support line. They make me feel not alone. They make me feel not depressed. Keep that in mind this week as you're at Black Hat, as you're at DEF CON, as you're at these events, meeting people and seeing old friends and making new friends. These are exactly what people need and exactly who you need to turn to when you have these types of problems for help and support.
So we're going to close up. These are our Twitter handles. Please follow us. We're going to have a Q&A across the hall. But then also tomorrow, Black Hat's been so kind to us to offer us an opportunity to talk to anyone else who's interested between 9:30 and 10:30 tomorrow in Coral C North Hall. Again, come and talk about your experience in the community. Please don't talk about any personal issues, but we'll be addressing this issue of suicide, burnout, and depression in the hacker community in more of a roundtable type format.
I'm also going to be tweeting out a link to a page of resources that I have for meditation apps, meditation books that I found to be very useful, but also other authors and other projects that I found inspiring, like Project Semicolon. So that way people can have more resources and more things that I have found to be very helpful personally that maybe you will too.
So again, thank you so much for listening to our talk, and let's continue the conversation across the hall. Thank you.